Spleen is an organ of reticuloendothelial system. In the practical exam, when you are given the conjoined viscera of spleen, pancreas and the duodenum, first you hold the spleen in anatomical position. In the practical examination, when you will be given the spleen, the pancreas and the duodenum, first you hold the spleen in anatomical position. Spleen has one medial end that is rounded and the blunt that is the anteriorly, that appears anteriorly, it is the its lateral head. It has an upper border and the lower border and the hilum. Alright. Now spleen lies against 9, 10 and 11 rib. So you make your 3 fingers like this. Hold the spleen here. Alright. And make it one end towards the back, that is upwards and medially, and another end forwards, downwards and forwards and laterally, and then a little downwards. This is the position of the spleen in anatomical position. Alright. It is tough sometimes to identify which one is its medial end and which one is its lateral end. And in between the superior angle and the anterior border, the angle is called the anterior basal angle, and behind the same thing constitutes the posterior basal angle. When the spleen enlarges, this anterior basal angle comes to your hand. Alright. Now spleen develops from the mesoderm of the dorsal mesogastrium. Behind the, and there are lobulated formation. There are multiple lobules which aggregates to form the main mass of the spleen, right? In front there is the gastrosplenic ligament and behind is the linorenal ligament, and it is a subdiaphragmatic organ. It is a subdiaphragmatic organ. The primordium of the splenic tissue has an serous coat and a capsule of fibroelastic tissue, and within it there are reticular fiber forming embedded in a amorphous matrix and presents multiple cells, that is erythroblast, myeloblast and megaloblast, for giving red blood cells, white blood cells and the platelets. Alright. After, in the embryonic period, spleen is a hemopoietic organ, but postnatally the hemopoietic function regresses and spleen becomes as a slaughterhouse for the senescent RBC as well as WBC and platelets. Spleen fights with the blood-borne antigens, not the tissue antigen. Spleen fights with the blood-borne antigens and microorganisms. Following splenectomy, especially the capsulated organism like pneumococci, and that's why before splenectomy we need to give pneumococcal vaccine. Before splenectomy we need to give the patient pneumococcal vaccine, so that as after splenectomy there will be poor immunity against the capsulated organism, that is the pneumococcus bacilli. Alright. Spleen removes as well as the senescent cells. It also removes the inclusion bodies, that is Haynes bodies in the RBCs, and the macromolecules that are formed in some storage disorder. In storage disorder, that is glycogen storage disorder, fat storage disorder. In such storage disorder, the spleen engulfs the macromolecules and eliminate cell. All right. The germinal center, that is in the white pulp. That is in the white pulp. The nodules that are formed by the lymphatic cells, that is T cells at the center, B cells in the middle, and the antigen presenting dendritic cells at the periphery. These nodules are much enlarged during any infection, and these nodules are called Malpighian bodies. Within the red pulp, you will see there are linear arrangement of cells. In the red pulp, you will see there are linear arrangements of cells like a string. These are called cords, and for the spleen, it is called cords of Billroth. In between the cords, the space is narrow, and RBCs need to cross these cords of Billroth through altering its shapes. As in aged RBC cannot alter its shape because its cell membrane is not adequate, and so there is lysis of the RBCs. In some situation, that is the hereditary spherocytosis, or in lymphomas, Hodgkin lymphomas, or myeloid leukemias, there is increased destruction of these RBCs, and so there is hemolytic anemia, as in thalassemia also. There is hemolytic anemia, and there is enlargement of the spleen. There is enlargement of the spleen. In case of enlargement of the spleen, that is called hypersplenism, you will see the spleen is enlarged, there is bleeding like from the esophageal varices. It encroaches on abdominal organ, that is on stomach, and narrows down the feeding capability. Understood? And there is, as well as there is hemolysis. This is called hypersplenism. So the indications of splenectomy are, that is hereditary spherocytosis, thalassemia, congenital hemolytic anemia, lymphomas, and myeloid leukemia. These are the indications for splenectomy, other than trauma or injury. All right. In case of trauma or injury, the operation is dangerous. When there is rupture of spleen, the operation is dangerous. Cold splenectomy is not so much dangerous. All right. You need to open the abdomen through a left paramedian incision, carve it a little along the parallel to the left hypochondrium, deflect the skin and muscle, then hold the splenic hilum, the blood vessels at the splenic hilum. That is called the pedicle of the spleen. All right. When you tie the pedicle of the spleen, you need to be cautious not to hold the tail of pancreas. All right. Otherwise, there will be diabetes. So you don't take the tail, avoid the tail of pancreas within the splenic pedicle. Then you cut it and deliver it from the abdomen. All right. Wash the abdomen if there is any bleeding. Then you put a drain. If there is too much bleeding, you can put a drain with the BD-vac arrangement and stitch. Put stitches over the muscles and the layers of abdomen. All right. This is the splenectomy operation. Now, you see what I have said. Whenever you are given the conjoined viscera, there is the spleen, the pancreas, and the duodenum. First, you hold the spleen in anatomical position, right? Then hold the pancreatic tissue and the duodenum, head of the pancreas within the curve of the duodenum. Now within the spleen, the primordium of splenic tissue, there are two areas, that is the white pulp and the red pulp. 75% of splenic tissue is the red pulp and 15% is the white pulp. White pulp means what? There are lymphocytes and mainly lymphocytes and macrophages around the arteries, which are called peri-arterial sheaths, which are expanded in case of the white pulp. And within this, as I have said, at the center is the T cells, in the middle layer is the B cells, and at the periphery there are macrophages and dendritic antigen presenting cells. Right? Now, within the spleen, from the capsule, there are multiple trabeculae or septa that divides the spleen into a lobulated structure. Through this septum passes the splenic artery as well as the splenic vein. Splenic artery gives rise to arterioles. Splenic artery gives rise to arterioles. And around the arterioles, these arterioles enters the splenic, these arterioles enters the splenic red pulp. After giving out the parallel branches, which are called penicillar arteries, Some of the penicillar artery directly communicate with the splenic tributaries of splenic vein through a structure which are called sinusoids, where there is interrupted lining of endothelial cells, and in between there are banana-shaped cells which are called stave cells that alter the shape of the sinusoid and control the entry of blood-borne cells into the sinusoid. And from the sinusoid, from the arterial end, sinusoids and the venular end, the splenic blood is drained. This is the direct channel. There is another channel that is called the indirect channel, indirect circuit, where the penicillar artery ends at the marginal sinus. The penicillar artery ends at the marginal sinus, and from the marginal sinus, the blood percolates the splenic red pulp. From the marginal sinus, blood percolates the splenic red pulp. From there, the blood seeps into the sinusoidal arrangement and enters into the splenic tributary, which is known as the indirect circulation. When radiolabeled dye is pushed into the spleen, it is seen that 90% of blood comes through the closed circuit and only 8 to 9% comes through open circuit. But as the area of red pulp is much higher, the passage of blood through the open circuit is of good amount, and the blood stays here for a long time with attachment to the macrophages and other cells, so that the senescent RBCs, WBCs and platelets can be removed, eliminated from the blood. Alright, so there is a closed circuit where the penicillar artery are communicated with the tributaries of splenic vein, in between connecting with splenic sinusoid. This is the closed circuit, and the sinusoids are interrupted, modified endothelial cells, and in between there are banana-shaped cells called the stave cells, which alter the shape of the sinusoids. Right? Now, another is the marginal sinus, that is the open sinus coming where the end point of the peninsular arteries is communicated, and from there the blood seeps slowly within the red pulp. Right? As I have told you, there are Malpighian nodules within the white pulp. Similarly, at the ends of the peninsular artery, there are ellipsoid bodies, which are holes of macrophages. Right? There is another term called high endothelial venule. I will tell you what is high endothelial venule in relation to lymph node. The spleen appears just at the cortex of a lymph node with the white pulp presenting the germinal center, and it is expanded when there is an infection. Spleen is specialized organ for removing blood-borne organism, not the tissue organism. Blood-borne antigens, not the tissue antigens. Right? And there are reasons there are indications for removing the spleen, like the thalassemia, hereditary spherocytosis, the Hodgkin's lymphoma, the myeloid leukemia, and the myeloproliferative disorder. Remember this term, alright? And removal of inclusion bodies from the RBCs, that is removal of Haying bodies from the RBC, as well as the macromolecules of storage that are formed during the formation of storage disorder, that is the glycogen storage disorder, lipid storage disorder. The spleen removes all these macromolecules. Before splenectomy, what we provide? We provide pneumococcal vaccine to the patient, right? And the indication for spleen, when the spleen enlarges, we palpate the anterobasal angle of the spleen, and spleen moves towards from the umbilical region to the right iliac fossa, because the spleen can rotate around its axis, taking the hilum as its axis and the thickness as the diameter. So the spleen, which was like this, it rotates like this, and the anterior basal angle comes in the front. If you percuss the spleen, if there is resonance, then you have to find whether the colon is coming in front due to enlargement of the kidney. And if there is no resonance, that means it is the splenic enlargement. There is no enlargement of the kidney which displaces the colon forward. Understood my point? So whenever you get an enlarged spleen, you don't forget to percuss over it. Alright. If it is resonant, it means there is simultaneous enlargement of the kidney, which is pushing the colon forward, and that's why the resonant sound is produced. If it is dull, that means kidney is not enlarged and the colon is not pushed forward to produce the resonant sound when you percuss the spleen. Right? Now, we always remember, as you have studied the lymph node, within these germinal centers, what happens? Whenever there is any infection, the germinal center increases in size, and both the T cells and B cells starts multiplying, and the B cells form the plasma cells from where the macromolecules or the antibodies come, and these antibodies coat the RBC as well as any microorganism that is entered into the blood. Remember, spleen always fights with the blood-borne and antigens and blood-borne microorganisms, not from the tissues. Right? So there is multiplication of the both T cells, B cells, and as well as with the macrophages. The B cells divide and subdivides and give rise to plasma cells and memory cells. And there are, as well as there are multiplications of T cells for cellular immunity. So T cells for cellular immunity, B cells for humoral immunity. Together with what is the role of the macrophages? Macrophages attaches to the RBCs, WBCs and platelets, and phagocytose the senescence or defective RBC, WBC or the platelets, right? And this is done by the antigenic presenting cells in the outer layer that are called dendritic cells. ठीक है जी? तो blood circulation in two parts, that is the closed circulation. One is closed circulation, that is the peninsular artery through the peninsular artery, through the sinusoids, entering into the blood is entering directly into the venous tributaries of the splenic vein, right? And from the peninsular artery, the blood is openly seeping, percolating the red pulp, and from there blood is entering into the tributaries of splenic vein. This is the open circulation. 75% of the 90% of the blood is returning through the closed circuit, and 8 to 9% is entering via the open circuit. As the contact time of the open circuit is slow, as it is slow, and there is a vast surface of the red pulp, so there is a good amount of. The spleen is a subdiaphragmatic organ that is below the diaphragm with pleura, forming the costodiaphragmatic recess. It is below the costodiaphragmatic recess. Spleen moves up and down with the respiratory movement. There are some smooth muscle fibers within the splenic tissue, but in case of human being, there is not so much contraction and relaxation of the splenic tissue till it holds some blood. It holds some blood to be given out in case of emergency. But in case of cats and dogs, the contraction and relaxation of the spleen is of considerable amount, and moving with the diaphragm, it can give out some storage blood into the circulation. Storage blood into the circulation. So during what I have said, during splenectomy, we need to tie the pedicle, avoiding the tail of the pancreas. Emergency splenectomy is a dangerous thing. Emergency splenectomy is a dangerous thing. As we very quickly give a paramedial incision, turn upward to the left, open the muscle and other layers, and take the splenic artery, its branches at the hilum and the vein and tie it, avoiding the tail of the pancreas. We deliver the spleen through the incision, stitch the layers of the abdomen, and put a drain if there is massive hemorrhage within the peritoneal cavity. Wash it and put a drain to drain the remnant of the bloods within the peritoneal cavity. Cold splenectomy is not that much, is not never done in haste. It is done slowly in the same manner. Right? What are the indications of splenectomy? What are the indications for splenectomy? And what is hypersplenism? What are the indications of splenectomy and what is hypersplenism? What are the clinical features of hypersplenism? Somebody please tell me the indications of splenectomy. What are the indications of splenectomy? Number one, thalassemia, that is the hemolytic anemia, congenital hemolytic anemia, yes. Lymphoma, Hodgkin's lymphoma, myeloid leukemia, hereditary spherocytosis, and in case of storage disorder, where there is a large, that is the fat storage disorder, glycogen storage disorder, there is a large enlargement of, there is a great enlargement of the spleen. What are the features of hypersplenism? How do you diagnose? This is hypersplenism. Number one, there will be enlargement, gross enlargement of the spleen, which encroaches on the other abdominal organ. Even it reduces the cavity of the stomach, producing early satiety. All right. And there will be bleeding, such as the esophageal, bleeding from the esophageal varices. And there could be hemolysis also. And the abdomen will become full with the enlarged spleen. Now, how will you palpate the spleen? You start palpating from the iliac fossa, right iliac fossa. All right. And you gradually move upwards and laterally to the left, and get the margin of the enlarged spleen. That is the anterior basal angle. That is the anterior basal angle. And remember to be able to hold the spleen during examination when conjoint viscera is given. Hold the spleen in between the 9th, 10th and 11th rib, paralleling with your 3 fingers. And this is its lateral end, and this one is its medial end. Then turn it slightly downwards. This is the position of the spleen, right? And as it is a subdiaphragmatic organ, the pleura, the lung and the costodiaphragmatic recess also come in relation to the spleen. All right. And as you have seen that this is the colon. This is the colon. C is the colon, colic impression, and the 2 layers form the phrenico-colic ligament. The 2 layers with the colon and the spleen, that is the phrenico-colic ligament. Right. Accessory spleen can be found close to the organ, number 1, close to the organ, number 2, in the greater omentum, greater sac, number 3, in relation to the left spermatic cord. Around the organ, nodules around the organ, in the greater omentum or in the gastrosplenic ligament, and in relation to the left spermatic cord. So I have given the gross anatomy, the histology, as well as the discussion on splenic circulation with clinical importance. All right. Thank you for listening.